Hello and welcome to ID Talk, Answers from an Infectious Disease Expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic, as well as today to give an update on where we stand. Today is Tuesday, August 25th of the year 2020. We have in the United States nearly 6 million total cases and over 180,000 deaths. However, the good news both nationally and statewide in Arizona is that the average caseload numbers have gone down for the last 7 days, and in Arizona's case, the last almost 14 days, as has the mortality rate, the death rates. So things are slowly starting to look up as things go down. Yeah, that made sense. So this week, we only have two questions. The first is a very important clarification from the last podcast, and this has to do with what we do about self-quarantining an individual who is exposed to a known COVID-19 case. As I reported in the last podcast, I was saying then that the individual could simply self-monitor for symptoms and if developing those, to refrain from going to school or for work. Well, the CDC in all cases has a blanket statement, a one-size-fits-all approach of self-quarantining for 14 days regardless. And those 14 days are after the initial exposure to an individual who was found to be COVID-19 positive. The slight challenge with that, and the reason that it's not a clear-cut issue, is that not all exposures are created equal. And that was in my mind when I was talking about this last time. For example, exposure to a child under the age of 10 conveys a very, very slight risk of exposure, as demonstrated in large population studies, including South Korea and Italy. However, age 10 through 19, and certainly adults, young adults and older, convey a much higher risk. So it kind of depends on who is exposed to what and when. As the easiest approach, and I am a huge believer in keeping it simple, sweetheart, is to just simply say a 14-day quarantine is the appropriate way to go. That said, if we have families whose exposure is a young child under age 10, we might wish to modify that 14-day period to simply being a symptom monitoring. But the official answer is, and officially from the CDC this still remains true, 14-day quarantine from date of initial exposure to a COVID-19 positive individual. The other question then, also an important one, is how long can we anticipate is the duration of immunity for patients who have been infected by and recovered from SARS coronavirus 2 or COVID-19? And is that immunity, both length and protective nature, dependent on the severity of the illness? Well, here again, the answer is it depends. There is certainly ample evidence that patients who even had mild or asymptomatic COVID-19 yet still have protective neutralizing antibodies for at minimum of 3 months or so, and that those individuals have a very low risk of being infected. However, in terms of detectable antibodies, that does differ in terms of severe versus asymptomatic or mild disease. The more severe the COVID-19 case, the greater the chance of having detectable antibodies for longer periods of time. It kind of makes sense. It's a direct relationship. That's not the same thing as saying that those individuals are at risk for or less at risk for recurrent infection. And up until very recently, the confirmed likelihood of reinfection or new infection with SARS coronavirus 2 had been zero. That has changed. There is a case coming to us from Hong Kong, a 33-year-old man who was definitely infected and sick in March, was discharged from hospital with negative testing, and now, although asymptomatic, has been found to have inflammation and new infection by all the indices available, meaning high viral load, elevated markers of inflammation like a C-reactive protein, and a virus that has strain delineation from a different part of the country. He was exposed in Hong Kong initially. The next strain apparently came from Europe. So far as people can tell, and this is pre-release, hasn't been published yet, this is just starting to hit the media right now, and I have not seen the report myself, but it does appear that this is the first case of true second infection out of the nearly 16 million cases worldwide that we know about. So Yeah, apparently it can happen. It's not a surprise. Certainly, that's the natural pattern of coronavirus. I would not be surprised by this whatsoever. But luckily, the risk for this is incredibly low. So fingers crossed that that's how it continues. All of that said, realistically, how does the immune system react to infection by the SARS coronavirus 2? It reacts just like it does to any other pathogen or vaccine, not simply in the creation of antibodies, but more importantly, in the creation of an adaptive immune response. That is T lymphocytes, CD4 or CD8, and B lymphocytes, all of which have been mortalized in response to that specific cluster of antigens. So, as with any other person who's been pre-sensitized by infection exposure or by vaccine, new challenge, new exposure by SARS coronavirus 2 will precipitate a cascade of events which is already there and waiting to go. That's the beauty of the adaptive immune system. So theoretically, and at least so far based on reality, the chances of somebody who's initially infected, regardless of asymptomatic or severely symptomatic, the chances of them becoming reinfected remain remote, and the chances of a persisting immune response, which is adaptive and able to cascade and be an escalated response, are quite high. So hopefully that's what we'll see. Keep in mind, everything I say today, we seem to get new evidence every day, which may add to that, I hope, or perhaps challenge that. So that's it for the questions submitted. As always, I do encourage you to submit questions, whatever's on your mind. Send it my way, and I'll do my best to talk at you and perhaps answer those. I thought then I would give an update on other issues which I think are active and are important for us as practicing pediatricians and healthcare workers who care for kids to know, and anybody else who's listening in on this podcast. The first is a very important issue, and that is the association and emerging trends of domestic violence and also non-accidental trauma, child abuse, and child neglect. We know from the National Children's Alliance that in the reporting half year from January through June of this year, 2020, that there have been 40,000 fewer cases of child abuse reported and followed up on, and children who have been able to be given resources and brought into safe space. Importantly, this does not mean 40,000 fewer cases of child abuse. This simply means 40,000 children have not been reported, based on national trends, have not been reported or brought to both medical and safe protection attention. Personally, and this is very much anecdotal, but in my exposure to the inpatient service at my hospital, the number of admissions for non-accidental or suspected non-accidental trauma and also just childhood trauma in general have been much higher for this time of year than one would expect. So it's out there, and I certainly encourage all of us who are frontline responders or perhaps point of portal of intake, so emergency departments, urgent care, primary care, absolutely, to be on the lookout for the signs and symptoms, as we all do anyway, of potential neglect, of non-accidental trauma, of child abuse. It's out there. Chances are high that it's higher than normal, given all of the fear and anxiety which is affecting everyone in today's COVID-19 day and age. So just please be out there and be aware. The next has to do, again, with the return to school issue and sort of by extension, the risk of children as being the infectious agents. Multiple times, I and others have referred to the large study coming out of South Korea, which broke down the risk of exposure from children as the index case into the age groups of 0 through 9 years and 10 through 19 years of age. Children 0 through 9 were found to have a 5% risk of conveying or infecting family members. Children from 10 through 19 years had an 18 or actually close to 19% chance of infecting family members. It now turns out, as the researchers from that study continue to go through the data, and keep in mind the initial data was a pre-release, but as they finish their numbers crunching, they're backing off from, or perhaps being more realistic in saying that it's unclear who infected whom in those families with children ages 10 through 19. And it is increasingly just as likely that an adult was the index case in those families as was the child from 10 to 19. This is not to completely backtrack from the appropriate phased opening of schools, kindergarten through fifth grade. I continue to believe, based on the data that I've seen, it is a relatively safer construct to consider than are the middle school and high school students. We all know that children of all ages express a whole bunch of virus in their nares, including SARS coronavirus 2, but how contagious they are remains to be seen. So it can only be by sort of observational and population-based studies that we can actually determine the true harm, the true risk associated with that. So keep in mind that there's still yet more to be discovered, still yet more to be discussed, and certainly an ongoing open and transparent dialogue as we look at school reopenings in person versus online needs to be continued based on what's out there. Vaccine updates. Okay, yes. I also personally believe, given the trends worldwide, that we're seeing that the only way out of the COVID-19 pandemic is through successful prevention, and that mask wearing and social distancing, while ideal if done properly, is not a valid option for many parts of certainly this country. We've just proven time again that human nature sort of flies in the face of appropriate social distancing and masking. So the true way out of this will be successful vaccination. Yours truly was the likely recipient of the messenger RNA vaccine through the Moderna trial, which is recruiting patients in Arizona, both based in Tucson and in Phoenix, several sites. It's a 30,000 patient study, phase 3 study, comparing messenger RNA vaccine to placebo. So, of course, I personally hope that A, I got the vaccine, and more importantly, B, that it works and is safe. That is one of 6 vaccine products worldwide that are in phase 3 trials. Now, that 6 includes the Sputnik V vaccine from Russia, which in retrospect is now being started on phase 3 trials after it was already approved by President Vladimir Putin for release to millions of healthcare workers and teachers in Russia. So that may be horse out of barn situation. I hope the vaccine is proved to be safe. Similarly, in China, a vaccine which was a live attenuated vaccine has been released to the military and now in retrospect also is going through phase 3 trials. However, in this country, the Moderna vaccine trial is ongoing and actively recruiting in Arizona. The Pfizer product is also now recruiting in phase 3 trials, although I've not yet been made aware that sites in Arizona are specifically recruiting for that trial. There are 2 others through AstraZeneca and the third one, which currently escapes me, but they're out there, they're recruiting. The hope continues to be to have a valid, viable, and efficacious vaccine, which is safe and effective, available for public release by January. We'll see how the timing is. It really depends on testing the efficacy of the vaccine in areas of the country which have a lot of disease. When first recruiting, Arizona was that spot, but as already noted, our numbers have been decreasing, and that's a good thing, but it may make it more difficult to achieve the statistical levels necessary to prove validity and efficacy of the Moderna vaccine. So stay tuned for more. It's coming. Treatment, since we're on sort of treatment, prevention, of course, I think is the most important part. Treatment of patients who are actively infected. And again, the most impactful or most efficacious intervention for those with severe to critical COVID-19 disease continues to be steroids. And not just steroids in general, but dexamethasone, in which the initial REACT study from the United Kingdom demonstrated clear treatment benefit for those who are severely sick and critically sick, with then a tapering of effect for those who are mildly ill. Studies now, of course, are looking at other steroid products, including the prednisone burst, which we've talked about. So the classic 5-day prednisone burst, 1 or 2 milligrams per kilogram per day, such as we use for patients with an asthmatic exacerbation. As it turns out, now longer-term studies looking at the 5-day versus a 10 or 14-day challenge with prednisone have found that the shorter course does not have any impact on the 28-day mortality or morbidity, which kind of makes sense. The dexamethasone treatment for COVID-19 is 10 days versus what we all think of for croup patients, which is a single dose or at most 3 doses based on hospital-based studies. So longer is better, and it makes sense because the cytokine storm, or at the very least the inflammatory reaction to infection by SARS coronavirus 2, does not mitigate or does not slow down after just a single 1 or 2 days of intervention. So it makes sense that longer is going to be better in continuing to carry that patient to clinical resolution. Again, personal anecdotal experience with the hospitalized COVID-19 patients that I personally cared for is that dexamethasone continues to be very positive in its impact on morbidity and mortality, but we are prescribing it for a full 10 days. Um, all of the hoopla still on the treatment subject about convalescent plasma. And this really, boy, I can't wait to, in retrospect, see the whole ups and downs story for this. This is sort of the off again, on again story. Only 5 days ago, the Food and Drug Administration and others had halted their proceedings to issue emergency authorization for use of convalescent plasma in COVID-19 patients. And then overnight, it seems that emergency authorization has been granted. Now, emergency authorization is not the same thing as approval. We need to be very clear about that. This is a product which may have benefit. Let's get it out there so that physicians can use it. Well, there has not been any challenge in getting access to convalescent plasma because many clinical sites, hospital sites, are enrolled in various studies, and certainly several sites in Tucson and certainly in Phoenix, in partnership with Mayo Scottsdale, have access to a convalescent plasma study. But the data supporting its use continues to be quite varied. There are several large, multi-center, well-conducted, placebo-controlled trials looking at the impact of convalescent plasma in patients with severe, critical, and even mild or asymptomatic disease requiring prophylaxis. And there has been no significant discernible benefit out of the studies. However, another study, which has recruited 60,000 individuals, this is a worldwide study, has found that if given in the first 3 days after diagnosis, that convalescent plasma does have a positive impact on outcome, hospital days, mortality, etc. The challenge with that study, though, is that it's not placebo-controlled, it's descriptive only, and there's a significant selection bias inherent in those patients who are selected to receive that intervention. So I am not here to dispute the potential or theoretic benefit of convalescent plasma, but simply to point out, as have others, including Dr. Fauci, that the science is not yet complete, and what science exists in benefit or in support of convalescent plasma is still weak. So before we rush out and start using plasma on everybody, I urge us to stay tuned for further studies and further well-controlled studies to help us with the intervention. If we had nothing else to offer our patients who are hospitalized or sick with COVID-19, then I would be a huge fan of trying everything. However, we have a very safe, a very well tolerated, and a reasonably effective intervention, that again being dexamethasone. So the pressure is off to save our patients, and instead we can do the right thing and explore in an evidence-based way proper interventions. Where else to go with this? Well, all right, so one interesting association which is still emerging, and so I bring it to your attention as something to follow. There seems to be, in 3 separate studies in 3 separate countries, an association with higher risk or higher attack rate of type 1 insulin-dependent diabetes occurring in children during that country's COVID-19 experience. Most recently, in the United Kingdom, a study was published, and this is a multi-center observational trial through the UK, and they had small numbers of children, as you'd expect for a small region in several hospitals. And so despite the small numbers, they saw an 80% increase in new diagnoses of type 1 diabetes in children in hospitals at which they were experiencing a COVID-19 surge. Similarly, population studies in both China and Italy have demonstrated similar increases. Anecdotally, again, our numbers are so small, I won't even care to comment on that, but it is something to be on the lookout for. So if you too, in your practices, are seeing an increase in new diagnoses, diabetes, it might be reasonable in Arizona for us to start sharing our data either through the chapter or perhaps through one of our friendly pediatric endocrinologists, and let's get our own population study going. There's no reason we cannot contribute to the weight of the global evidence for this possibility. Transmission. This is an ongoing hot topic, especially because we have the opportunity to care for humans at the start of life, and we certainly are faced with the concerns, risks, and questions about peripartum, prenatal, and postpartum transmission from a COVID-19 positive mother to her baby. So new chapters in that ongoing saga have to do with the assessment of the risk of breast milk transmission and breastfeeding transmission. As it turns out, and this was just published in the Journal of AMA, that infants who were exclusively breastfed by mothers who were known to be COVID-19 positive had very low risk of developing disease, as evidenced by PCR-based testing constructs. This is great. This is fantastic because that's been an ongoing concern, similar to the questions raised about perinatal or postpartum transmission of human immunodeficiency virus, of HIV. In that situation, there is real risk. And one has to balance the risk of poor nutrition in under-resourced part of the world, third world countries, for example, who must have breast milk for nutrition and survival, versus in the developed countries, such as the United States, et cetera, and so forth, where we have other options that we can provide our babies. But in the case of COVID-19, it seems the risk is low. We'll never say zero. There are no absolutes in medicine, of course. But it does seem that we can counsel or support the continued use of breastfeeding in babies born to COVID-19 positive moms. Similarly, the concern of transplacental or prepartum transmission. Yes, several case reports have been published, which, as far as we are able, have demonstrated that transplacental transmission did occur. Again, it's very difficult because one cannot test the babies pre and post without knowing when the exposure was and without having access to prepartum blood, except in unusual circumstances. So, the risk of transmission is always going to be greatest after delivery and via normal respiratory droplets. So in the setting where mother is known to be positive and newborn baby, we are screening babies, and if they're screening to be negative, then mother wears a mask until she is 10 days out from diagnosis, asymptomatic for 3 days, et cetera, and so forth. The usual sort of resolution of isolation protocol. So, there's no end story to this yet, but I think we can take some comfort in that any risk of transmission in the peripartum period from mom to baby is quite low. Yay. And then finally, just in terms of the testing question, because these come up frequently, yes, the healthcare worker obtained nasopharyngeal swab remains the gold standard, both for brain biopsy, yeah, right, because I experienced one of those, and that was no joke, let me tell you. But in terms of actually getting cells, getting testing validity, and having both positive and negative predictive values for the results. The NP swab, which we perform, or our nursing staff or whomever, which we obtain, is far superior to the patient-acquired nasopharyngeal swab. And it makes sense, because technique is what it's all about. However, studies are now looking at alternatives to that, and a big one, which we've all been asking about, is the impact of saliva-based specimens. And so here again, the key is in getting not just pure saliva, but saliva which has some sort of respiratory epithelial cells, especially those from the nasopharynx. So in patients who had simply a saliva specimen submitted or an oral pharyngeal swab saturated in saliva, it turns out that had very similar positivity rates to the healthcare worker-associated nasopharyngeal swabs. That's great news because it's far less invasive to get the oropharyngeal or the saliva swab than it is the nasopharyngeal swab. Next yet, in terms of research, will be a head-to-head comparison of the oropharyngeal swab versus saliva versus healthcare nasopharyngeal swab in terms of validity of testing. But there's hope that we may no longer have to torture ourselves and our patients as much as we currently do to get a swab which has a valid testing potential. So that's where we're at. That's the state of the world. A whole bunch, I hope, of good news, some cautionary notes, certainly in terms of safety issues at home, and also a possible association between SARS coronavirus 2 infection and diabetes, which, by the way, I will say scientifically makes sense. Pancreatic islet cells are high expressors of the ACE2 receptor, which is bound to by SARS coronavirus 2. So it kind of makes sense that one may either upregulate both insulin production and or burn out those cells, and so the patients are insulin deficient. Lots yet more to be discovered in that, lots more yet to be discovered in terms of vaccine research and prevention efforts, but I surely hope that our numbers will continue to improve and that we'll continue to do the right thing in our response to that. So thank you once again for listening to ID Talk. Arizona AAP members can submit questions for future episodes to COVID, that's COVID, at azaap.org. And I do encourage you to do so, even if you think it's a silly question. It's highly likely it's not a silly question unless I can't answer it, in which case, who cares? No kidding. I do want to hear your questions. Send them my way so we can talk about them on the air. For more information and resources related to COVID-19 in Arizona or to learn how to become a member, please visit azaap.org. And on the COVID Education channel, you will also find a new blog by my friend and colleague, Dr. Nathan Price, who is also pediatric infectious diseases through the University of Arizona. Dial in and see what he has to say too. He'll be summarizing the state of current research as am I trying to here. So thanks again for listening. Have a great next week. Hang in there, folks. Be safe, be sane.